Welcome. In this session, we'll be discussing about macular telangiectasia. Macular telangiectasia was initially described as an entity with an onset in adulthood and presenting with mild blurring of central visual acuity due to exudation from ectatic retinal capillaries in the juxtafoveal area in one or both eyes. Gas et al. Originally proposed a classification system for macular telangiectasia, classifying it into four types. Type 1 macular telangiectasia is an unilateral disease with characteristic aneurysmal dilatations of juxtafoveal capillaries and intraretinal exudation as seen here in this clinical photograph. Type 1 macular telangiectasia is considered to belong to the spectrum of Coats disease, which, as we have discussed in the previous session, is also a unilateral disease with characteristic aneurysmal dilatations of retinal blood vessels and exudation in the retina. Type 1 macular telangiectasia is further classified into Type 1A, which occurs predominantly in young adult males, and Type 1B, which occurs in middle-aged males. And visual acuity in both Type 1A and Type 1B macular telangiectasia is relatively well preserved. Type 2 macular telangiectasia is a bilateral disease with minimal exudation and is considered as a primarily neurodegenerative disorder. It occurs predominantly in an older group of patients in their 5th to 6 decades of life and has a female preponderance. Type 3 macular telangiectasia is a very rare entity and is a bilateral disorder characterized by telangiectasia progressing to capillary occlusion, and it can occur in either sex. Iannuzzi et al. Updated the classification system of macular telangiectasia and described type 1 macular telangiectasia as being a unilateral disorder presenting with aneurysmal dilatations of juxtafoveal capillaries, and type 2 macular telangiectasia as a bilateral disorder which does not show visible aneurysms. In the remainder of this session, we'll be discussing about type 2 macular telangiectasia, which is the most common among these relatively rare group of disorders called macular telangiectasia. Macular telangiectasia type 2, also called MacTel type 2, is a rare disease and, as we have mentioned, is the most common type of macular telangiectasia. The mean age at diagnosis of macular telangiectasia type 2 is 60 years, and females are more commonly affected than males. MacTel type 2 patients have a high prevalence of diabetes and hypertension, and 10% of eyes with MacTel type 2 have associated diabetic retinopathy. The primary etiology of MacTel type 2 is considered to be disruption of the Macular cells of the retina, and so MacTel type 2 is considered to be primarily a neurodegenerative disease, and the Macular cell disruption leading secondarily to changes in the juxtafoveal capillaries. Genome-wide association studies by the MacTel project has discovered 3 genetic loci associated with MacTel type 2. Patients with MacTel type 2 usually present with loss of central visual acuity, typically slowly progressive, and impaired reading vision is the most common complaint among these patients. In the ongoing study called the MacTel project, 37% of eyes with MacTel type 2 had a visual acuity of worse than 20/50, with only 3.8% of eyes having a visual acuity worse than 20/200. Moderate visual loss in MacTel type 2 is usually associated with the clinical features of right-angled veins and intraretinal pigmentation, which we'll discuss, and severe visual loss in MacTel type 2 occurs due to foveal atrophy and macular neovascularization, which occur in the late stages of the disease. Other symptoms include scotoma, loss of contrast sensitivity, and early loss of stereopsis. As we have mentioned, unlike MacTel type 1, MacTel type 2 is typically a bilateral disorder but is usually asymmetric, and the lesions tend to initially occur temporal to the fovea but usually progresses to ultimately involve the entire parafoveal area circumferentially. The first clinical sign of MacTel type 2 is usually loss of retinal transparency with grayish discoloration of the involved area of the retina, as seen in this color photograph of an eye with early MacTel type 2 and in this color photograph of an eye with more advanced MacTel type 2. And this grayish discoloration is followed by dilatation of capillaries, mainly in the deep capillary plexus. As we have mentioned earlier, exudation does not occur in eyes with MacTel type 2. Crystalline deposits, as seen here in this clinical photograph, occurs in the vitreoretinal interface in eyes with MacTel type 2, and these crystalline deposits probably originate from Muller cell disruption. A characteristic feature of MacTel type 2 is the presence of blunted and dilated venules or arterioles, but more commonly venules near the ectatic capillaries, as seen here in this clinical photograph. Normally, arterioles or venules become narrower as they approach the fovea, but these blunted and dilated venules or arterioles of MacTel type 2 dilate as they approach the fovea and make a right angle turn as they dive posteriorly towards the deep capillary plexus. RP hyperplasia and intraretinal pigment migration occur surrounding these diving vessels and appear as pigmented plaques, as seen here in this clinical photograph and also in these two clinical photographs. We can also see the blunted and dilated vessels in these two clinical photographs. Loss of foveal depression may appear as an altered foveal reflex, and longitudinal follow-up over years can demonstrate tissue contracture with dragging of tissue towards the disease focus in the temporal juxtafoveal area. Lamellar or full-thickness macular holes can occur in eyes with MacTel type 2, as we will discuss, and macular neovascularization of MacTel type 2 is retinal in origin, arising from the deep retinal capillary plexus, being fed by retinal arteriole and drained by retinal venule. It usually follows the formation of the right angle blood vessels and interretinal pigment migration, which we have just discussed, and usually lies temporal to the fovea. Although exudation does not occur from the dilated capillaries of MacTel type 2, neovascularization in MacTel type 2 may result in hard exudate formation along with intraretinal edema and intraretinal or subretinal hemorrhages, as seen here in this clinical photograph, and the neovascularization may ultimately be followed by disciform scarring, as seen here in this clinical photograph. One of the characteristic diagnostic signs of MacTel type 2 is loss of normal central hypoautofluorescence. In a normal FAF, the central macula appears hypoautofluorescent because of presence of macular xanthophylls, which blocks light used to generate autofluorescence from the underlying retinal pigment epithelium. In MacTel type 2, there is a loss of this macular xanthophyll pigment, resulting in patchy areas of increased transmission of autofluorescence from underlying RPE, as seen here in this clinical photograph. We may note here that one of the major sites of storage of macular xanthophylls are the Muller cells, which are considered to be the primary site of pathology in MacTel type 2. And this is better detected with blue light FAF as compared to green light FAF, because blue light is more efficiently blocked by macular xanthophylls than is green light. And as we have mentioned, this loss of normal central hypoautofluorescence is one of the earliest signs considered to be diagnostic of MacTel type 2. Punctate hypoautofluorescent areas are also found in FAF images of eyes with MacTel type 2, corresponding to areas of intraretinal pigment migration. Fluorescent angiography shows characteristic telangiectatic capillaries in the early frames of the angiogram, with staining of the involved zone in later frames of the angiogram. This occurs in the temporal parafoveal area in the early stage of the disease process, but involves the entire parafoveal area circumferentially later in the disease process. And when neovascularization develops, fluorescent angiography shows leakage and staining from the neovascular network. On optical coherence tomography, we find a temporally enlarged asymmetric foveal pit early in the disease process due to asymmetric thinning of the parafoveal retina more temporally than nasally. Later cavitations are found in the retina in the foveal and parafoveal areas, as seen here in these OCT photographs, and cavitations are the sign leading to the diagnosis of MacTel type 2 most commonly, and this is important to remember. These cavitations are neither detected ophthalmoscopically nor do they leak on fluorescent angiography, and these cavitations are usually oblong, oriented parallel to the retinal surface. Cavitations may change in size and shape over time, and some may even disappear, but the overall trend is progression of these cavitations, resulting in loss of retinal tissue and foveal atrophy. which leads to reduction in central visual acuity, cavitations under the internal limiting membrane, and cavitations involving the full thickness of the fovea may progress to rupture of the overlying retina, resembling a partial or full thickness macular hole, and cavitations in the outer retinal layer may disappear, leaving a zone of ellipsoid zone loss as seen here in this B-scan OCT, corresponding to this in-phase OCT segmented at the layer of the ellipsoid zone. A mound-like lesion called the outer retinal hyperreflective lesion may form in eyes with MacTel type 2, and loss of ISOS junction or ellipsoid zone can occur in areas of cavitation as we have mentioned, and also in zones of outer retinal hyperreflective lesion. In eyes with MacTel type 2, intraretinal hyperreflectivity may be found mostly in the outer retina as seen here in this OCT, often with posterior shadowing, and this intraretinal hyperreflectivity can be due to either intraretinal pigment migration, intraretinal non-exudative neovascularization, or retinochoroidal anastomosis. This OCTA overlay of B-scan OCT shows blood flow corresponding to this intraretinal hyperreflectivity, and following development of macular neovascularization, subretinal fluid may be detected on OCT. OCT angiography typically shows dilatation, tortuosity, and non-perfusion of capillaries with increased intervascular spaces, usually involving the deep retinal capillary plexus. OCTA may also show evidence of tissue contracture by demonstrating dragging of surrounding blood vessels towards the disease focus temporal to the fovea. OCTA can also pick up macular neovascularization when it develops and reveals that macular neovascularization of MacTel type 2 originates from deep retinal capillary plexus. The original classification system of macular telangiectasia by Gass and Blody was based on clinical findings and was described prior to the advent of OCT, OCT angiography, and fundus autofluorescence. The MacTel project described a new classification system in 2023 based on clinical and diagnostic signs which have been correlated with loss in visual acuity such as ellipsoid zone loss, intraretinal pigment, and OCT hyperreflectivity. Grade 0 describes macular telangiectasia with none of these findings, but may have other clinical findings of macular telangiectasia such as retinal graying, right-angled veins, fluorescent angiographic leakage from ectatic capillaries, and fundus autofluorescence signs which we have described. Grade 1 describes macular telangiectasia with non-central ellipsoid zone break. Grade 2 describes macular telangiectasia with a centrally located ellipsoid zone break. Grade 3 describes macular telangiectasia with intraretinal pigment located non-centrally. Grade 4 describes macular telangiectasia with intraretinal hyperreflectivity on optical coherence tomography. Grade 5 describes macular telangiectasia with intraretinal pigment located centrally, and Grade 6 describes the development of exudative neovascularization in an eye with macular telangiectasia type 2. Differential diagnosis of MacTel type 2 include macular neovascularization of neovascular AMD, which needs to be differentiated from macular neovascularization from MacTel type 2. Like macular neovascularization of MacTel type 2, type 3 macular neovascularization of neovascular AMD, also known as retinal angiomatous proliferation, arise from deep retinal capillary plexus, but type 3 macular neovascularization of neovascular AMD is associated with pigment epithelial detachment, which does not occur in MacTel type 2. And in contrast to eyes with type 1 and type 2 macular neovascularization of neovascular AMD, eyes with macular neovascularization from macular telangiectasia type 2 does not show drusen or RPE changes. Also, other features of MacTel type 2 such as right-angled veins, intraretinal pigments, and cavitations on OCT are not found in eyes with macular neovascularization from neovascular AMD. Also, tamoxifen retinopathy may have pseudocystic foveal cavitation resembling cavitations of MacTel type 2, and tamoxifen is known to be toxic to the Muller cells of the retina. Neovascularization from macular telangiectasia is treated with anti-VEGF injections, and an intravitreal ciliary neurotrophic factor implant has been approved by FDA in 2025 to treat the neurodegenerative component of MacTel type 2. This implant contains genetically modified RPE cells which are able to secrete CNTF, and this implant is surgically positioned within the vitreous cavity, and a phase 2 trial showed that sham-treated eyes had 31% greater progression of neurodegeneration as reflected by progression of area of EZ loss on NFS OCT as compared to eyes treated with CNTF implant over 24 months. Anti-VEGF injection has been found to be deleterious for non-neovascular MacTel type 2, and surgery for full-thickness macular holes from MacTel type 2 have a lower success rate as compared to that for idiopathic macular holes. To recap, macular telangiectasia is characterized by dilated telangiectatic capillaries in the posterior pole, and two broad types have been described. Type 1 is unilateral, occurring in younger males, and is characterized by aneurysms and exudates temporal to the fovea, resembling Coats disease. Type 2 is bilateral, occurring in the 5th to 7 decades of life, having a female preponderance without visible aneurysms or exudates. Patients with MacTel type 2 present with slowly progressive loss of visual acuity, metamorphopsia, and/or scotoma. Clinical examination shows involvement of the temporal parafoveal region, which may progress to encircle the fovea circumferentially. Typical signs include graying of the retina with loss in its transparency, dilated capillaries in the deep capillary plexus, and crystalline yellowish dots in the vitreoretinal interface. With disease progression, right-angled venule with or without surrounding intraretinal pigment migration and foveal atrophy may be found. End-stage lesions include lamellar or full-thickness macular hole formation and subretinal neovascularization, which may lead to scarring. Fluorescent angiography shows dilated capillaries which leak and stain the retina in the involved region temporal to the fovea. Fundus autofluorescence show hyperautofluorescence in the foveal region because of loss of macular xanthophyll, with patchy areas of hypoautofluorescence corresponding to regions of intraretinal pigment migration. SDOCT shows cavitations in the foveal region, intraretinal hyperreflectivity, and areas of ellipsoid zone loss. OCTA demonstrates dilated capillaries in the disease focus temporal to the fovea and shows dragging of surrounding retina and its vessels towards the disease focus. Differential diagnosis includes tamoxifen retinopathy, and neovascularization of MacTel type 2 needs to be differentiated from neovascularization of age-related macular degeneration. Treatment includes ciliary neurotrophic factor implant to reduce progression of MacTel type 2 and intravitreal anti-VEGF injections when neovascularization develops. Thank you for listening.